A male in his 50s presents to the ED with back and abdominal pain as well as a fever. He has a post-contrast CT of his abdomen and pelvis in a portovenous phase. The reporting radiologist made a great pickup on this scan. Can you see the abnormality? Let's go through the case. With any abdominal or back pain, remember to assess the psoas major muscles which originate from the T12 to L5 vertebrae and transverse processes before joining up with muscle fibers from the iliacus muscle and inserting into the lesser trochanter of the femur. If we look at the psoas muscles on this scan, we can see there is some asymmetry. The right psoas is larger than the left, and we've lost some of the fat planes within the muscle. As we scroll down, we can see there is fat stranding surrounding the psoas muscle extending into the pelvis. What could this psoas enlargement represent? A psoas abscess could account for this. This can be primary, occurring in immunosuppressed patients and diabetics, or secondary from a collection elsewhere in the abdomen, or even an adjacent spondylodiscitis. You may see peripheral enhancement and fluid density on CT, although this isn't always easy to see. A psoas haematoma again can be primary, seen in patients taking anticoagulation or with hematological disorders, or it can be secondary to trauma or a ruptured AAA. They can be difficult to differentiate from abscess formation on CT, and the clinical history is usually useful. Clinical correlation is advised. But if there is high density within the psoas, this can point towards a haematoma. It is possible to have tumour invasion within the psoas muscle, although it is unusual to see this just within the psoas and nowhere else. It's more usual to see tumour infiltration into the psoas from elsewhere within the retroperitoneum. Usually this happens with metastatic disease rather than a primary lesion. If we look at a coronal view of the CT on bone windows, we again can see some subtle enlargement of the right psoas muscle, and importantly the endplates of the vertebrae look maintained, with no erosion that you may expect to see with a spondylodiscitis. The reporting radiologist picked this up and recommended an MRI to assess the psoas and look for a spondylodiscitis. Due to pain, the patient could only tolerate a few stir sequences, so we don't have a complete scan. On this axial sequence, there is high stir signal within the right psoas muscle which is expanded, with these locules suggesting abscess formation. High signal within the psoas on stir in the context of back pain and fever highly suggests spondylodiscitis. If we look at a lateral stir sequence of the lumbar spine, we can see high signal in the lateral aspect of the L3-4 disc, which is then continuous with the abscess formation within the right psoas. The findings on MRI now suggest a spondylodiscitis with secondary psoas abscess formation. These usually present with back pain and typically over the age of 50. There may be a history of infection elsewhere, whilst things like immunosuppression, steroid use, diabetes and IVDU can increase the risk. It usually involves a single level, but several levels can be involved, for example in tuberculous discitis. The infection usually involves both the vertebral end plate and disc, and in adults is thought to arise in the end plate first. And so although we couldn't see this on our CT case, irregularity of the end plates can be seen after a few weeks on X-ray and CT, as well as loss of the disc base. On CT we may also see psoas and epidural abscesses, which can help make the diagnosis. MRI is more sensitive, and we're looking for high T2 or stir signal within the end plates, disc and paraspinal tissues and psoas muscles. Gadolinium contrast can help, as we may see enhancement of the end plates, disc and peripheral enhancement of any abscesses. It's important on MRI to ensure there is no significant central canal stenosis secondary to abscess formation or vertebral collapse. Most commonly, discitis is initially treated with a long course of antibiotics, and in this case we can see a good response on imaging, with improvement in the right psoas abnormality at 2 months. The learning point here is not to miss the psoas muscles as a review area on abdominal CT, and MRI is best for assessment of spondylodiscitis.